Our next presentation is from Dr. Bob Haennel. He received his PhD in physical education from the University of Alberta and went on to complete a postdoctoral fellowship in the Division of Cardiology at the Faculty of Medicine at the University of Alberta. He holds an exercise specialist and program director certification from the American College of Sports Medicine. From 1990 to 2005, he held a joint appointment with the University of Regina's Faculty of Kinesiology and Health Studies and the Regina Capella Health Regions, where he directed the cardiac rehabilitation exercise program. He spent the last 15 years at the University of Alberta, where he served first as the chair of the Department of Physical Therapy and now serves as the dean of the Faculty of Rehabilitation Medicine. He's also a member of the Research Advisory Committee for the Mazankowski Alberta Heart Institute. His current research program includes examination of the impact of exercise training in the rehabilitation of heart failure patients who have undergone cardiac resynchronization therapy, an assessment of daily activity in heart failure patients with preserved versus reduced ejection fraction, and an examination of high-intensity interval training in the rehabilitation of patients with congenital heart disease. So I'd like to turn it over to you, Bob.
Good morning, ladies and gentlemen, or good afternoon if you happen to be further east. It's a pleasure to be here with you today. As you may have heard, it's a beautiful sunny day here in Edmonton, and just a perfect day to talk a little bit about heart failure. I hope everyone recognizes that heart failure is a national issue for us. We have about 250 to 300,000 Canadians each year are diagnosed with heart failure. And it actually is a serious cardiovascular consequence of a number of different things that can cause it. So I thought what I would do today is walk you through a little bit of the pathology, how we manage it, and then we'll get into the exercise stuff. First and foremost, when we look at this, when we look at heart failure generally, first thing you have to recognize is that the basic pathology of heart failure is the inability of the cardiac pump to function properly. It simply doesn't pump effectively. And because of this, the cardiac output is lower. And if you want to skip the next 2 points, the third point there is probably the most important one. We start to see an increase in pulmonary and venous and central venous pressures. And this is a consequence of ventricular volume overload and the elevated left ventricular filling pressure that are above in the points. My little diagram there, which I spent hours working on, so I hope you appreciate it, basically gives you a sense of what it's like to have heart failure. You wind up with a low cardiac output, and because of that low cardiac output, you start to see blood supply to vital organs being diminished. The blood flow to the kidneys is lower, and as a result of that, the kidneys respond by doing retention of fluid, and this gives rise to buildup of fluid in the lungs and the veins, and the swelling of the ankles, which are fairly common among heart failure patients. Now, I apologize for the business of the slide, but it just gives you a little bit of an indication in terms of what causes heart failure. It can be caused by a prior myocardial infarction, where you see loss of myocardial mass. It can be caused by a cardiomyopathy, which is where you've got a weakening of the heart muscle itself and you get impaired contraction. It can be caused by chronic hypertension, pressure overload, and it can be caused by volume overload. At the end of the day, what happens to the patient who has heart failure is they start to see hypoperfusion. So a hypoperfusion, and they start to see pulmonary congestion. Those are the two end results of what takes place when you look at heart failure. Now, heart failure just doesn't typically occur on its own. It's usually a consequence of some other underlying pathology, such as hypertension or perhaps having a prior myocardial infarction. The end result, though, is they start to see a lot of fatigue. They start to get dyspnea, and they see swelling in the periphery. Now, in terms of heart failure, you should recognize most of us, when we think of heart failure, we think of it as a failure of the pump to function properly or to contract properly and reduce cardiac output. But there are, in fact, two different broad classifications of heart failure. There's HFpEF and HFrEF, which is in the clinical. If you go over to the Heart Institute, this is what they talk about. And when you talk about HFrEF, we're talking about systolic heart failure where there's an impaired contractility or ejection. And this is caused by, and this is characterized by a reduced ejection fraction. When we talk about a reduced ejection fractions, usually we're talking about an ejection fraction that is less than 40. Some people will argue that it means less than 35 or 30%. But in any event, it is a reduced ejection fraction. On the other extreme, we have diastolic heart failure, or HFpEF heart failure, with a preserved ejection fraction. In this particular example, the impairment is related to filling and relaxation of the ventricle. What is interesting is much of the research to date has been done on the HFrEF version of heart failure, where we're dealing with reduced ejection fraction. And one of the characteristics of the HFpEF, the diastolic heart failure, is that it tends to be seen more often in older women than it does in men. Whereas in HFrEF, reduced ejection fraction, we see it affecting men and women. So we have two different types of heart failure in terms of the broad classification. The way in which the impact of these particular conditions ultimately comes back to impacting an individual's ability to perform activity. For those of you that have worked in clinical environments, you'll recognize the New York Heart Association functional classifications. Oftentimes what happens is they will define and classify an individual based on their symptomatology. And it'll be in the case notes of the patients as well. For most of the people online here who are recreation therapists, exercise physiologists, exercise specialists, you'll be familiar that most of the people we're going to work with are going to be in the class 1, class 2, and in some instances, class 3. Class 2 simply talks about these men and women experiencing slight limitations in their physical activity. They're comfortable at rest, but when we give them ordinary physical activity, it results obviously in fatigue. It may result in some dyspnea, palpitations, and possibly angina. But there are only a slight limitations to their activity. Class 3, which is the more serious form, obviously, of heart failure, we start to see marked limitations of physical activity. They're comfortable at rest, but just less than ordinary activities will result in fatigue, dyspnea, palpitations, and possibly angina. For the most part, anybody that's on this call will not be working with class 4 patients. These individuals are unable to carry out any physical activity without discomfort, and they're suffering from symptoms of cardiac insufficiency, which are often present even at rest. So for our purposes, we're usually talking about class 1, class 2, and in some instances, class 3 patients. We're dealing with people who have got slight to marked limitations in their activity. When you know the New York Heart Association classifications, it's going to help you with respect to what you should expect from the individual and what you can actually recommend to that individual and what they might be able to do and be able to tolerate when it comes to physical activity. Now, obviously I had a little too much time on my hands the other day, so I've gone to my horse analogy again, or in this instance, I guess it would be more of my donkey analogy. When you look at people with heart failures, the first thing you have to recognize is they usually have a long history of dealing with a comorbidity. Most heart failure patients are going to be on a variety of medications, which are designed to actually deal with the fatigue and the overload of the heart. Case in point, they will be on diuretics and they'll be on ACE inhibitors. The diuretics help relieve the fluid retention, all right? And this is going to help increase their exercise tolerance. And one way to look at it is it's unloading the heart in terms of the volume of fluid going through it. ACE inhibitors prevent the formation of potent vasoconstrictors, such as angiotensin II. This reduces the systemic vascular resistance, which in turn simply means the heart can pump again, is pumping out against a lower resistance. So again, unloading the heart. Beta blockers help in terms of just simply minimizing the range with the heart rate response that you can get, and it makes it a little easier on the heart to manage the loads that are coming in. It gives it a little more time. Your end diastolic volume is increased, your filling time is increased. And of course, the most not common one you're going to see in heart failure is digoxin, which is a positive ion. Now, these classic medical interventions that are going And of course, everyone will recognize, in addition to this, we're going to see recommendations with respect to diet, use of substances such as smoking, as well as exercise as an intervention. Just a really simple little, oh, there we go. Now it's going to go forward. Oh, too far. Apologies. Okay, this is the classic exercise prescription that's recommended for individuals with failure. And I'm going to walk through it, then I'm going to walk through some of my concerns that I have with respect to what's up here from the American statements of 2003 and improvements since then. It talks about aerobic activity, where the intensity should be between 50 and 80% of the 40 to 60% of the heart rate reserve, or peak VO2. Oftentimes what you're going to find is you don't know their peak VO2, and their heart rate reserve is going to be impacted by the beta blocker. So it may be easier for all of us to simply remember the best way to do this is to use some simple parameters to measure intensity, such as the rating perceived exertion, whether you're using the 20-point scale or the 10-point scale. Keeping in mind that the other arguments that you can use is simply observing your clients to determine that they should be sweating and they should be breathing a little hard, but they should not be experiencing dyspnea. These are simple measures that we can use to monitor intensity. Ideally, we would like our individuals with heart failure to do 20 to 30 minutes of activity every day with a goal of 150 minutes a week as a minimum. There are caveats to this though. The first and most important thing is if you remember the primary problem with heart failure, it's the inability of the heart to pump out sufficient blood and reach the periphery where it's needed. You need to make sure that you have prolonged warm-ups and longer cool downs. This is going to allow them to get to a steady state. It just takes longer for them to get into steady state. And of course, we're going to focus on low intensity, longer duration activities. If you choose to go to interval exercise, the normal sequence that we would often use is a 1-to-1 or 1-to-2 work to rest ratio, simply meaning 1 to 2 minutes of exercise on the bike followed by a corresponding duration of rest or free movement. Frequency, usual sequence, 3 to 5 times a week. And there is no particular modalities. The one thing I would say with heart failure patients, if you're working with heart failure patients, it's nice to have them on modalities that are easy to monitor blood pressure and easy to keep an eye on. Can they do resistance exercises? The answer to that is yes. High repetition, slow intensity. In the last 20 years, there's been lots of data that come out and suggest that heart failure patients can indeed do resistance exercises in bands, machines, or free weights. Again, remember proper technique, avoiding the Valsalva's maneuver, and using high reps and low intensity. With respect to flexibility, I can go back 25 years ago. We published a paper on Tai Chi, and we found that it was a wonderful way to assist patients with heart failure with maintaining range of motion and giving them the sense that they're actually capable of doing the exercise. In fact, in my prior life, when I ran a rehab program, we'd often use Tai Chi and yoga as the start point for the exercise program for heart failure patients, just to give them a sense of that they could actually perform the activity. And over time, we would introduce the aerobic activity and resistance training. We wanted to get them into the habit of coming to us. We wanted to get them in the habit of being able to, seeing that they could accomplish the activities. And then over time, we started to introduce additional activities such as aerobic training and resistance training. Now, one of the things that we have spent time on the last while, as a number of groups have, instead of looking at that 20 to 30 minutes of continuous exercise, for those of you that have worked with heart failure, oftentimes that's too much. They get tired, they'll get dyspnea. They'll get that shortness of breath, they're winded, and they simply get fatigued. So a number of us are looking at this saying, well, let's look at aerobic interval training. And just as a side note, where this idea for me, where it hit me the first time, was I was working at the Heart Institute, and the exercise facility was on the second floor. And we would have patients in the heart failure group who would come up to the exercise facility, but the elevator was too far away. They would come up the stairs, 2 flights of stairs, and we'd have to meet them at the top of the stairs because they were already exhausted. So we found very quickly that interval exercise
Bob,
That's
your audio
about the intensity of this particular point. Simply ask you to consider a 1-to-1, 1-to-2 ratio to try to get them to the point where they're capable of getting through that, repeating it to the point of 20 to 30 minutes per day, and gradually moving from the interval exercise to continuous exercise if the patient is capable of doing it. And in front of you on this slide, I've simply given you two versions of exercise that we've done in the past. One of them relates back to aerobic interval training, and the other one relates back to a little bit more of an anaerobic interval training program. Now, as we move on, what are some of the things? Oh, for those of you that have never seen me, that's my picture in the top corner there. What about this aerobic interval program, and why do we want to do it? Well, it allows these individuals, if you think about heart failure, many of the activities that they do are actually verging on anaerobic. I mean, they can manage an activity for 1 minute to 2 minutes, and then they get tired. So this is playing into their strength, the areas that they need to be able to do in order to function on a day-to-day basis. So the aerobic interval training gives the opportunity of doing higher work intensity and allowing these men and women to get greater work done. The problem for you as the professional working with them is that because you're doing the intervals, their exercise blocks in your schedule are a little longer because they've got longer recovery intervals. Another thing that happens with this aerobic interval training program is that lactic acid accumulation tends to be less compared to continuous work. Again, we start to see high energy phosphates being replenished in the recovery. The bottom line here is that there's a little less fatigue for the individual. And so they're able of achieving greater and expending more calories than they do in a regular aerobic session. But I do caution you, it depends
sorry,
upon
Bob,
the person.
I need to just interrupt quickly. Can you repeat that last statement? The audio seems to be cutting in and out.
Oh, it isn't me. So what I was simply referring to, thank you, Nora. What I was simply saying is when you look at interval training programs, they do have the advantages with respect to allowing people to do more work and burn more calories in a given time frame for people with limited capacity. It also allows for a reduction in lactate accumulation simply because of the recovery intervals and the replenishment of high energy phosphates. And this gives rise to less fatigue. But I would caution everyone, when you look at someone who has heart failure, here's the scenario that I will look at. Many cardiac programs and many programs that are run in the community, you don't have VO2 data. You're simply meeting these people, you're getting their histories, you're getting a sense of what they've done in the past, and you're setting your exercise prescription. You have to think about, well, is this patient capable of doing 10 minutes of continuous exercise? And the first day or two, you're going to be playing with your exercise prescription because you're learning from the patient in terms of what they're capable of doing. The other confounding factor for heart failure patients is when you look at interval versus continuous activity. Heart failure patients are a particular challenge in cardiac rehab. One of the main reasons is an individual can come in and perform very well for you on a Monday. But when you see them on a Wednesday, they walk in and they're already spent. They're tired already. And so there's no consistency. If you look at a bypass patient or an MI patient, you pretty much can watch from day to day to day and see the ability of the individual to produce and work at the same level pretty consistent. With heart failure patients, especially when you get into class 2, later class 2 and early class 3, you're going to be dealing with patients who will come in one day and they'll do just fine. The next day they come in, they may do just fine. But the third day they may come in and be very tired before they arrive, and so you have to modify your prescription accordingly. The important thing here with heart failure patients is getting to know your patient. Getting to know them, and having conversations with them to get a sense in terms of where they were at today versus 2 days ago in terms of activities and in terms of the responses to these activities. Now, just before I leave the aerobic interval exercise stuff, this is just data from Wislof's paper back a number of years ago. And it just gives you a sense of what happens when you start asking someone to do the interval training in heart failure, and you see that not only did they outperform those who did the continuous exercise training, 20 minutes of continuous movement, their VO2 increased above that, as well as those that didn't train at all. So it does work. One of the challenges with the interval training course is that, in fact, it takes longer to do things. And this just simply gives you a slightly different perspective of things. This is from Meyer's paper back a number of years ago. And he was measuring the actual cardiac stress, the rate pressure product, basically. And he found that those that were doing the interval training program, their cardiac stress was less than what they would have seen if they would have been doing a continuous movement at an intensity of about 75% of VO2. That's identified by the horizontal dashed line. So what they're seeing, and this is probably the best example of what I'm trying to get across to you, is they're capable of doing more work at a lower load on the heart. And that's one of the advantages of aerobic interval training. Now, the exercise training that you're all involved in, and this to me is probably the most important slide of my presentation. You need to watch your patients carefully. First thing I would suggest is every place I've ever worked at, any heart failure patients come in, the first thing we did, we always weighed them before every exercise session. What we were simply trying to determine whether there was an unexpected weight gain. And especially when people first start exercising with us. They're new heart failure patients. Let's say they came from a facility where we didn't have aerobic testing done from the physicians. So we had to set an exercise prescription for them, and we would do our best based on subjective numbers and observations. And what we would be watching for is how well did they manage it. The first thing that we'd always look at and ask them is, okay, you came in on Monday for the first time. How did you feel Tuesday? Were you tired that longer than a day? Another nice example is how well did you sleep that night? A lot of people, if we tend to give them too much exercise, they have trouble sleeping. So we look for persistent fatigue that lasts more than 24 hours. We want to watch for dyspnea, that shortness of breath that we talked about, and see if it gets worse as we start giving them exercise from day 1 to day 2 to day 3. We're going to watch for that nocturnal dyspnea, that at night when they go to bed and they're sleeping. Does that show up? If it's showing up more frequently, it usually means something. And that's when you start thinking either I'm giving them too much activity, or in fact there's something more nebulous going on and we may want to refer them back into the healthcare system. Certainly you watch for an unexplained weight gain. If they start retaining fluid, because of the exercise, you're going to see a large increase in weight, and if it starts to climb up and there's no other explanation for it, and it lasts and it starts to persist for a period of 1 to 3 days, you're probably giving them too much exercise, or again, it may be that there's something going on with respect to their heart's ability to cope. My favorite marker is always to watch for the swelling in the periphery. Simply check the sock line. If someone comes into my clinic and they're saying they were tired and they're feeling a little winded, I will always ask them, so let's lower your sock. Is that line, is it more prevalent today than it normally is? It gives you an idea of whether there's some peripheral edema going on. Again, that's simply a sign of inability to cope. Watch for a resting heart rate. The resting heart rates should always be less than 100 beats a minute. If they're not, it usually means something. And of course, we watch for obviously systemic illnesses and fevers. Keep an eye on the blood pressure. Blood pressure, oftentimes in the heart failure patients, is hard to hear if you're doing it without an automated system. But watch to make sure that we're not seeing a post-exercise hypotension taking place. And if so, keep them in the clinic as long as need be until the blood pressure normalizes. And for those of you that happen to have electrocardiograms available to you, obviously you're going to watch for ventricular arrhythmias of any sort. But for the most part, most of the clinics that I've worked in, we haven't had that in the exercise room available. So just keep that in mind. You guys all know a great deal about exercise. In fact, I would argue most of you know more about it than I do. But the one thing that I've observed over 35 years of working in this is that when we look at asking a patient to exercise, as long as they are in a program, you've got a reasonable expectation of success. The challenge is, and there's lots of data to show this, is that we really may not be hitting the behavior, because once we finish the actual exercise rehab program, with these people. About 50 to 60% revert back to their normal active lifestyle, or their normal level of activity in their lifestyle. What I mean by that is about 50% simply no longer follow the activity recommendations that you're giving. And that's a problem. It's great that they'll do this while they're in our clinics and in our facilities and when we're watching them. But if we're really good at what we do, they should be picking this up and doing this as they go forward on their own. And that's the ultimate goal of all these rehab programs. Now, the other thing to keep in mind is the rehab programs that we have for cardiac populations, only about 15 to 25% of the eligible patients actually participate. And while most patients, including heart failure patients, view exercise as being really important, only about half of those people actually do it. So we really do need to rely on your behavioral expertise to help these people get into the habit of being active. And the line I put at the bottom, 61% of the cardiac patients, in this instance were heart failure patients, considered adhering to exercise the most difficult, the more difficult relative to the other recommendations, which obviously include diet changes and cessation of smoking. So it is a challenge. And when you think about heart failure patients, usually they've got a long history of problems before they get to the point where they have heart failure. And you have to recognize that they've heard this, they've heard the importance of exercise repeatedly, but how do we convince them to become more active and keep on doing the activity once they're finished with us? So this is where my world, as an exercise physiologist, I went, some people argue, I went to the dark side because I really think we might be missing some of the point here. When we start looking at individuals with heart failure and exercise, and everybody wants to talk about maximal aerobic power, they want to do an exercise test. I actually think the bigger issue we need to look at is how active are they? How active are they in their daily life without us, without our interventions? And I give you some evidence of this. Daily physical activity, this is from Belen, I can't see the chap name, he's from Italy. Daily physical activity closely linked to exercise capacity and heart failure clinical status. So daily activity is tied to these things and gives us some sense with respect to prognosis. Adherence to exercise training is a problem, and that's what I was just alluding to. There's just 3 studies. I could probably give you 20 more that all say the same thing. The exercise training element, when we simply bring people in and we say, okay, let's get on a cross trainer, let's get on a bike, let's get on a treadmill, may not be the best answer for long-term adherence to the behavior. Daily activity may be easier than exercise to fit in daily life. Well, what's interesting about that line is for many heart failure patients, daily activity and exercise actually merge into one. Most of us think of daily activity as unstructured and with variable intensities. When we look at heart failure patients, when we start talking about walking, they can actually be in their intensity range simply by walking around the neighborhood. So this is one of the reasons that I and others suggest that we need to assess the daily activity, because it provides us
Sorry, Bob, you just cut in and out again.
Now,
if you can repeat that last bit.
Do what they value in their daily life. Are we dipping in and out again?
Yes, if you could repeat that last little bit, please.
Yes, if you could repeat that last little bit, please.
Starting from where?
Probably the last minute.
Probably the last minute.
Sure. So I'll go back to the top of this slide. And again, my apologies. I don't know why we're having trouble with the audio. The focus of this slide really is talking about daily activity. And the short version of what I was saying is that I think as exercise specialists, as recreation people, as healthcare providers, one of the things we need to start doing is checking our clients before they begin the activity to see what they're normally doing or what they're typically doing before they get engaged with us. A really good example of this is there obviously these the pedometers and then the accelerometers have all become very popular in terms of measuring steps, et cetera, et cetera. One of the things you're going to find with heart failure patients is the vast majority of heart failure patients do less than 3,500 steps, 3,700 steps a day. So if you use that as a marker, you're really dealing with a very sedentary population, okay? And in fact, that daily activity does link well to the clinical status and prognosis. And if you're working with your client on a regular basis, they've got, I don't care if they're using their phone, I don't care if they're using a sensor armband or any other pedometer or accelerometer. If they're using it consistently, you'll get some indication in terms of whether there's a change in the amount of activity that they're doing. And that can actually be very helpful in terms of moderating, changing and their activity program, but also recognizing changes in their own status. Just to give you an example, most of you recognize that in order for individuals to gain the health benefits of physical activity, healthy older adults, and when I say older adults, I'm talking about people in their 60s, 70s, 80s, etc. We'd like to see them accumulating between 6,500 and 8,500 steps a day. With chronic diseases such as heart failure, we often see that they only take between 3,500 and 5,500 steps a day. And in heart failure specifically, it's down even lower. It tends to be closer to the 3,500 range than anything else. And the most important point on this slide is this, is that when you start seeing an individual with heart failure, where their step count is dropping down to under 3,700 steps a day, their risk of mortality is increasing. So it gives us motivation to try to keep these people active in their daily living. And let's be candid, most people that are in big cities, if they can, they would rather exercise in an environment they're comfortable with, which may mean their home, in their neighborhood, in their local recreation facility. So using things such as steps to help guide us is a reasonable approach to maintaining an active lifestyle, which is probably as important as the VO2 is that we typically look at. I think I'm just about ready to wrap up, Nora, but here are a few points. Heart failure patients are usually assessed using exercise capacity, but the variance in their daily activity should be considered. And in fact, for many of the people online, you're not going to have the ability to do a VO2 max test, and doing predictive tests simply don't work in these individuals. So using markers of daily activity can be considered as a good indicator in terms of whether you're having an impact on the individual's ability to adhere to the active behavior. With respect to daily activity and exercise, there is no difference between those that have HFpEF and HFrEF. HFrEF being the systolic heart failure and HFpEF being diastolic heart failure. Okay? Most of the activities that we're looking at with heart failure patients were in the mild range. And when I say mild range, I'm talking about less than 3 METs. And in studies that we've done around here, our heart failure patients typically only average about 3,000 steps a day. And the simple suggestion is that we really should be trying to get them up towards the 7,000 steps per day. The last slide I have for you really is, this is just an example of another intervention that I've worked with for a number of years for heart failure patients. And it's called CRT, which is a cardiac resynchronization device. It's a very complicated pacemaker which increases the contractile ability of the heart. And this is from a study we did. We simply looked at the daily activity continuum in patients who got this device pre and post. There was no exercise intervention. This is just pre and post. And what we found was these people spend about 80% of their day being sedentary, which actually wasn't bad because we've got other studies that show us that heart failure patients spend about 90% of their day being sedentary, 90 to 95% to be specific. But in this particular example, we looked at sedentary, which is waking time, and we defined it as less than 1.5 minutes. Mild activity, which that 1.6 METs to 2.9 METs, most of us would think of that as activities of daily living. And then moderate to vigorous exercise, the concept of a structured activity program, a structured exercise program where we're dealing with intensity, time, intensity, duration type of activity, etc. What you saw when we put this device in people was that the only real difference that happens is in the mild activity range. Excuse me, this is in the range of activities of daily living. So the device, while it is effective in increasing aerobic capacity, typically it gives rise to an increase of about 1 MET, the device itself when it's implanted. But in terms of the practicality of it, once it's implanted, you have an increased aerobic capacity, you're not seeing a big change in the higher levels of activity. You're seeing changes in the mild range, which is in the activities of daily living. So if I have one message for the group online, one, I think many of you are capable of working with patients with heart failure, keeping in mind that you always have to watch their status as they go from day to day to day, all right? And always remember that in cases where you're not certain what to do, err on the side of caution and refer people back to the healthcare system. I also encourage you to start looking more so on the behavior that they're doing rather than on the aerobic capacity. Aerobic capacity, I don't mean to say it's not important, because I think it is, but that daily activity and what they're capable of doing throughout the day is probably more important to that individual, but is equally valuable to aerobic capacity in terms of monitoring how successful you are as their therapist, as their consultant, in terms of helping them maintain an active lifestyle. And I think, Nora, with that, I will wrap up.
Okay. Thank you for your presentation. We have a couple questions from the chat. Can people hear me? I just need a thumbs up, I guess. Okay, so the first question is, can you define prolonged warm-up and cool down in the number of minutes?
Usually we're talking, for heart failure patients, we're usually talking about a 5-minute warm-up. Like if I just take a bicycle ergometer exercise, usually we're talking in the range of 5 minutes, and the cool down in the range of 5 to 7 to 10 minutes, depending on the person.
Okay. Next question, would the 6-minute walk or 40-meter walking be a useful assessment tool or useful assessment tools? That's the first question.
Sure. My answer to that is a qualified yes. And I say this because when you look at the 6-minute walk test, you need to recognize there's a very strong learning component to it. And when we do the 6-minute walk test as part of our research, we do one 6-minute walk test. We let the person rest for a half an hour. We do a second one. And then we see if there's a variation of more than 10%. If there is, we do a third one, another half an hour later. Again, you have to be careful. Just to do one 6-minute walk test can be misleading, because sometimes patients will take the 6-minute walk test as a challenge and they'll go hard. And then they'll be spent. And heart failure patients, oftentimes they'll do the 6-minute walk test and that's all they're doing today. I guess my point to you would be, if you're going to do it, you have to do it properly. And I would suggest doing it at least twice on an individual to make sure you've got a reasonable starting point. Same thing for the 40-meter.
Okay, the second part of this question is, what would one expect to see from an O2 SATs perspective post-aerobic interval?
O2 SATs, the hope, of course, is the O2 SATs are staying very high at 98. Again, 98, 95. In terms of the SATs that we're looking at, remember, when we're dealing with the aerobic interval activity, we're dealing with mild to moderate activity. So we're not pushing, we're not going up to 75 or 80%. What I didn't get into today was the high intensity interval training that some people are pushing for. I'm using high intensity interval training program for my study I've got going on right now on congenital hearts. These are young men and young women who've had repaired congenital defects. And it works fairly well in that population. I don't recommend it for heart failure patients, simply because it's a high intensity, and in that particular population with that particular type of interval training, you're going to see a drop. The O2 SATs will drop down. Hopefully they're not going to drop down to the point where they're 88 or 90, but they can be, you can see them lower in that population if you do the high intensity interval training. But what I was alluding to was we're talking about relatively moderate intensity.
There's a question about whether, sorry, Bob, continue. We have a question about whether people are making use of the PAR MedX forms in community settings when getting participants with
We
health
have a question about
conditions.
whether people are making use of the PubMed forms in community settings when getting participants with health conditions.
Sorry, I'm going to need you to repeat that. You broke up on.
I sounded interesting. It sounded like I was on helium.
It sounded interesting. It sounded like I was on helium.
Yeah.
Okay, I'll try again.
Could you repeat the
Okay,
question?
I'll try again.
Are many people making use of
Are
the
many
PARMEDX
people making
forms
use of the
in a
PubMed
community setting
forms
when getting participants
when
with
getting
heart conditions
participants
seeking
with heart
exercise?
conditions seeking exercise?
And
Have you-
any indication of how medical professionals are understanding and accepting the use of these forms?
Yeah, so there's a few things that it's a bit of an interesting interface when you start talking about, okay, you're let's say you're a fitness consultant or you're an exercise specialist or a rec person, anyone or allied health professional, and you're working in a community setting, and you get people coming in for exercise. Okay, the PARMEDX is again I've seen a number of responses to the PARMEDX, including I'm not filling this out unless somebody pays me, to yep, I can fill this out, to why am I filling this out, and what are you doing with that individual. So you'll get a range of responses. The one thing I would suggest though is if you're using the PARMEDX, it does a nice thing and it opens a dialogue between yourself as the fitness person or the exercise person and the healthcare provider who is filling out the PARMEDX. Keep in mind that what I have had a number of interesting discussions with cardiologists, with internists, with family doctors when they say you shouldn't be doing this, is the line I occasionally heard over my many years. And I would say, but if I don't provide them with some guidance on exercise, who's going to? Because that's an issue. So I did use I did use the PARMEDX when I worked in Saskatchewan and actually as well as in Alberta here. And the acceptance of it was variable by the physicians who were filling it out. But I really felt that it at least informed the physician what we were talking about doing. We oftentimes attached another form with it saying, this is what we're proposing to do with this individual. But to get some clearance from the healthcare system, especially with heart failure patients, is not a bad idea.
Okay, the next question is about what is the acceptable medical clearance required? Is it a GP prescription or a cardiologist's approval?
Interesting question. Don't have an answer for you. It varies from place to place to place. A very good example is, I can give you illustrations of where I've seen people in smaller communities and individuals come in and want to exercise, and they're going to, prior life, I worked at the Y when I was a young man, and I had patients with heart conditions coming in and wanted to exercise. It was like, should we be allowing them in the facility? Well, how can we stop them? The point that I would make here is if individuals come into your facilities and are using your facilities, they may not even declare that they have a health problem, okay? Because they may, then they're going to send me to do the PARMEDX, or they're going to want a physician clearance. I guess the thing I would look and say is if you meet a client and you're interviewing the client and doing your history with the client, and you discover that they have a history of heart failure, bypass surgery, MI, these types of things, your comfort level would be probably enhanced by sending a note back to the physician saying, this chap wants to do an exercise program, do you perceive any problem? I don't think I would not be recommending people to say, okay, well, you've had heart failure. Oh, that's fine. Come on, I'll work with you. It'd be good to have some background, because a lot of times when you talk to patients, some patients are incredibly knowledgeable. They'll turn to you and say, yeah, I'm on a beta blocker, I'm on DIBS, I'm on ACE inhibitor. Other people will turn to you and say, I'm on a blue one, I'm on a yellow one, and I take the red one twice a week. So again, if you're going to start working with people, the more information you have about that person, the better off you are. The one thing I will suggest to you is that, you guys are the exercise experts, and that's a given. But the understanding of pathology is crucial to knowing what to do and how to proceed with patients. I don't care if they're cancer patients, stroke patients, or heart patients. You need to have an understanding of what's going on in them, so that you've got a reasonable expectation of success and not getting them into any trouble. So Do you need a cardiologist referral? A lot of the formal rehab programs require it. Other programs will literally say there is a system in place where anybody goes through the hospital is automatically referred. So there's no one simple answer to this. I would always recommend people think about what they're talking, who they're talking to, what their circumstances are, and how comfortable are you with what they're telling you that they have. And then when in doubt, refer back to the physician.
Okay, are there any other questions from the group before we move on to our next presentation? I'll leave it just for a moment to see if anyone's typing in. Okay, seeing no new messages, I want to thank you, Bob, for taking the time to prepare the presentation and spend part of your morning with us. I appreciate your expertise in being able to share that with our practitioners.